story. So my disclosures are shown here, and none of what I'm going to say had any commercial support or government support. I'm going to talk mainly about the direct trial, which was charitably funded from Diabetes UK. And I mentioned here also that the slides, or many of the slides for the direct trial, are up on the website, and a lot of other information, directclinicaltrial.org.uk. Now, I'm going to speak mainly about type 2 diabetes, and that is because type 2 diabetes, when I was a student, was considered sort of little brother of type 1 diabetes, something it happened in older people who didn't matter very much. And as a disease, it mostly didn't cause too much trouble. You took a pill and came back in a year's time. But we did know, we believed, that it was a permanent condition, it was incurable, and that it was progressive. So if you were unlucky and developed it young, then it could cause trouble. Now, things have changed absolutely radically since I was a student. And the main thing is that the onset of type 2 diabetes has moved down from an average age of nearly 70 down to about 50. Low 50s, 51, I think, in the UK. And that means that most people who develop this disease do get disabling, painful, and completely incurable complications. And here's a list of them. These are dreadful complications. This is a very serious disease. And I'll show you one more slide to sort of cement this idea. I've listed here 3 diseases which most people would consider to be important diseases. Most people who develop breast cancer are worried, frightened, and treat this seriously. They would, if offered treatment for remission, which might be chemotherapy with very nasty side effects, they would take it every day as instructed, because this is a serious disease. It has an 80% 10-year survival. 80% of people will live 10 years with breast cancer on average. Non-Hodgkin's lymphoma is a much worse cancer, taken very seriously, and it has a 60% 10-year survival. So 60% of patients will live 10 years. Type 2 diabetes, which is a similar age distribution to these cancers, only 50% 10-year survival. This is a very serious disease, and we need to take it much more seriously. And what we've learned in recent years is that type 2 diabetes is not a separate disease, the little brother of type 1. It is, in fact, all part and parcel of what we now call the disease process of obesity. So disease process as defined by the WHO, and I think perhaps the Scottish Sign Guideline of 2010 got in there first to say that obesity is not a BMI of 30 or a BMI or waist or something like this, but it is a process, a metabolic process with genetic, epigenetic, and environmental factors in its etiology, and is a progressive condition which starts at one point and moves to others, and obviously reveals itself in different ways to different people. One way it reveals itself is by developing type 2 diabetes and metabolic syndrome. So that's the story. And we know that this disease is terribly closely related to weight gain. This is a very famous study from Graham Colditz in North America, which shows that at the left-hand side here, with a body mass index of 22, this is a very comfortable place to be. And you'll notice that somebody, that is me actually, on the top of a mountain in the Alps with a body mass index of 22. And at that level, I can expect to climb mountains for many, many years. However, body mass index of even 25 has a relative risk of about 8 to 10. That means people have 8 to 10 more likelihood of developing diabetes than perhaps I would. I'm lucky, but that's how it is. With a body mass index of 30, the relative risk is 30 to 40 times, and this risk goes up to astronomical levels. This association cannot be by chance, it is causal. And we know, obviously, also that the epidemic of type 2 diabetes, developing over the last 30 or 40 years, has followed the epidemic of obesity. We now talk of them as a syndemic. It's the same condition. It's 2 epidemics which are totally linked and running together. It's the same disease process, and it's called obesity. Now, we also know, there are many studies confirming this, that quite modest weight loss can prevent the onset of diabetes. And you've heard from our previous speakers this evening that the onset of diabetes can be delayed or perhaps even prevented completely by quite modest weight loss. By modest, I mean what can be achieved with a dietitian. In these studies, this is the Diabetes Prevention Project, about a 7-kilogram weight loss, maintained quite well, half of that weight loss maintained for 4 years. And that was enough to knock out, to prevent more than half the new diabetes. And you heard from Jenny Ram Miller that this can be achieved with different diet types. It doesn't really matter what the diet type is. They all have the same benefit. If there is weight loss, it will prevent the onset of type 2 diabetes. Our question was, can we actually take one step further and tackle the disease itself once it has been diagnosed, once it's developed? And some of the strength behind this came from a very old study we did in Aberdeen in Scotland, published in 1990. And here's the slide from that paper. And what this shows is on the x-axis, the years of life lost with type 2 diabetes. These are people who are overweight, BMI over 25, with type 2 diabetes, according to their weight loss in the first 12 months after diagnosis. So this is the weight loss achieved with the help of the dietitians in the clinic. In those days, every patient was seen in the diabetic clinic, was seen by doctors and by dietitians who reinforced the message that weight loss is vitally important. Some lost weight, some didn't. Those who did not lose weight, 0 here, died approximately 6 or 7 years younger than people who never had diabetes in the same population. And that figure, approximately 6 or 7 years younger, is still the case now, with much more recent data from big European studies. So despite our modern treatments for diabetes, people are still dying younger through complications. And this is tragic because so many of them develop the disease at a much younger age. Now, as they lost weight in this old study, you can see their survivals increased. And we published data up to 14 kilograms weight loss, at which point the survival of our people with overweight type 2 diabetes, their survival was exactly the same as people who never had diabetes in the same population, the general population in the north of Scotland. And that suggested to us that 14, and I sort of moved up to 15 kilograms, it's a nice round figure, it's approximately 2 stones in our patois in Scotland. 2 stones weight, 15 kilograms weight loss would be associated with return to a completely normal life expectancy. That suggests that disease process has been knocked out. This was using retrospective data from people who were followed for many, many years. It was not a randomized controlled trial. It was supported by some evidence from bariatric surgeons who've been saying for years that with their sort of weight losses, that type 2 diabetes can go into remission. And this is a collection of studies in different centers using different operations. The blue columns show the data at 2 years. And if you run your eye across this, you can see that 72, 75, 68, 85% of patients were in remission at 2 years using different operations with weight losses of 23%, 45%, 35%, 33%. The green columns show that that's 10 years or 6 years. The remission rates have fallen. So some of the people who were in remission at 2 years are no longer in remission at 5, 6, 10 years because they have regained weight. And even after bariatric surgery, there is weight regain later. But these data suggest that this disease really should be reversible. The question, though, is could we achieve this with a lesser weight loss than these heroic bariatric surgical approaches? And the answer came from really a single study from John Dixon and his colleagues in Melbourne, in Australia, published many years ago now, 2008. And this is a very small study, but it was a randomized controlled trial between bariatric surgery, gastric band surgery, and continuing in the diabetes clinic. And what they looked at in this diabetes at 2 years, and this slide shows in the open symbols, those individuals who are no longer diabetic at 2 years. And you can see actually most of these who had surgery were no longer diabetic. The figure is 73% compared with just 2, and that makes 13% of the patients who continued in the diabetes. And I have put a line in this slide at 15 kilograms, the same figure that we derived in our Scottish study. People who lost 15 kilograms, 83% were no longer diabetic. A fantastic figure. Now, if we could translate that into large numbers of ordinary people and perhaps achieve it without surgery, this would be very exciting. John Dixon and his colleagues actually put their line at 10%, and they got exactly the same figure because there's such a small study, there are no patients in that interval. But I felt that it was safest to go for the 15 kilograms weight loss rather than 10% based on our Aberdeen experience. And that was the sort of driver behind establishing the DIRECT trial, Diabetes Clinical Remission Trial, which showed, well, I'll tell you the results, but this was a study which aimed to look at whether it was possible to deliver a weight loss program for people with diabetes, type 2 diabetes, in primary care. And it's quite an ambitious study with the aim of achieving remissions. And it was the first study ever to be designed with a non-surgical approach aiming for remissions of type 2 diabetes. And I might tell you it was a very long process to be able to get funding for this, because many people did not believe that we could achieve remotely the same sort of weight losses or sustain them. And they felt that the patients would not be willing to do this kind of intervention. These people critics were fortunately wrong. The study was conducted in Scotland, across Scotland, in many villages up and down the country, and in the northeast of England, together with my colleague Roy Taylor, who took a subset through some mechanistic studies in Newcastle, and I'll show you those as well briefly. Study design was very simple. We randomized practices and the people in them to either continue as control practices where they received best practice guidelines for all the current treatments for diabetes and methods of follow-up. That is the SIGN guidelines in Scotland and the slightly newer and more bulky NICE guidelines in England. And the intervention group received exactly the same quality of care with the same guidelines, plus an intervention program, which I shall show to you. And we aim to recruit very, very ordinary people with type 2 diabetes. And these are people, and I can show you their criteria here. We aim to get people from 20 to 65 years of age. We had an upper cutoff only because we intended to follow them up for a number of years afterwards, and we quite like them to remain alive. The average age was 54 years, and that was with an average duration of diabetes of 3 years. So their average age of onset, 51, was exactly the same as that across the country. We limited the restriction, recruitment to people with less than 6 years duration of diabetes. And the reason for that is because we know that with much longer durations, over 10 years, then remission becomes less likely. And these people, because of short duration, were not yet on insulin. So we didn't include people on insulin in this study. They came from more deprived areas of the country, and we selected them on purpose because with multiple deprivations, diabetes is more common, and it's also more difficult to treat. So we picked a pretty tough group here. Their average age was 54, I mentioned. Their body mass index was 35, again, fairly average for a group of people with recent onset type 2 diabetes. The intervention was delivered entirely by practice nurse or dietitian, if there was a dietitian available in primary care. So they only saw a doctor once, really just to check that they were happy to do the study and to agree that we could do a remarkable thing on day one, and this is day one, when we asked all our participants to stop their anti-diabetes drugs, all of them, and their antihypertensive and diuretic medications when they're used for treating blood pressure. The reason for that, and Neris has sort of hinted at this in her presentation, as did Tony Leeds, was that this is for safety reasons. If you then go on to day two, or later on in day one, when they start a total diet replacement program, 830 kilocalories per day, formula diet, nutritionally balanced, perhaps the best, most perfect way of ensuring safety during weight loss. But if you do that with glucose-lowering drugs, there is a risk of hypoglycemia. So we asked them to stop all medications on day one and to monitor blood glucose just using finger prick tests. And that included metformin. All the drugs were stopped. This was also a very big incentive for our patients and motivation to continue. They were very appreciative of the opportunity to be able to manage their diabetes without medication. Similarly, if you were to go on to total diet replacement of this level and continue the antihypertensive or diuretic drugs, then blood pressure can fall rapidly with dizziness, postural hypertension, and even blackouts. So for safety reasons, we asked them to stop the medication, but of course we then monitored the blood pressure and had a protocol for reintroducing the medication if necessary, and in some cases that was necessary. So the total diet replacement was very similar to that you heard about in the other studies, 830 calories a day, balanced for all the nutrients. It was not a particularly high protein diet, I'm pleased to say, because high protein diets are getting bad press for complications now. And we then moved on after 12 weeks approximately to a food reintroduction phase. That 12-week period was flexible. And the reason we did this was because some of our participants did have holidays coming up or weddings or reasons why some days or some groups of days they couldn't actually do the total diet replacement. But we agreed that it was, provided they notched up the equivalent of 12 weeks over 20 weeks, we could allow them to continue in the trial. And during that term, they were seen regularly by a qualified dietitian or a qualified practice nurse with training in the program, who prepared them, and this is very important, during this period when they don't have to think about their food intake at all, they simply take the formula diet, prepare them to reintroduce meals one by one, and then to go on to weight loss maintenance. And I think it'd be fair to say that this food introduction was the most stressful part of the program for our patients. We notionally had a 2-month period to do this. Many of our participants found this difficult. They had to then make decisions, and they couldn't go back to eating in the way that they were eating before they lost weight, because if they did that, then their weights would inevitably return. So we sometimes allowed them a longer period to introduce meals one by one. They then went on to their weight loss maintenance phase. And this was, again, carefully designed not to be a high carbohydrate or low carbohydrate diet. It was not high or low in anything. It was a very typical nutrient profile, similar to that of the UK, if there is such a thing as the UK, with between 40 and 50% of energy from carbohydrate. Most of our participants elected to go nearer the 50%, but we allowed those who wish to have slightly lower intakes to do so. None of our participants wanted to follow any kind of radical diets in their long-term weight loss maintenance. During that phase, we did also allow them to use one meal replacement a day, a formula meal replacement, the same formula diet as we had used in total diet replacement. And many of the participants did elect to do that to make the weight loss maintenance phase easier. We also allowed or included what we called a rescue plan or relapse management, such that if their weights increased by 2 kilograms during weight loss maintenance, we offered them a 2-week or even 4-week period back on total diet replacement to get them back on train. And many of our participants, about a third of them, did take up that offer at some stage. And it was reassuring for them from the very beginning to know that that was going to be an offer, that they were going to be helped in the weight loss maintenance phase and offered relapse management if necessary. The design of the study was to try to get more than 20% of our patients into remission. And this was considered a very, very radical thing at the time. We, as I mentioned, it was doubted whether this was remotely possible. We aimed for 22%. And that was because our public health doctors in the UK said that we would have to then make a change in the strategy for managing type 2 diabetes if this could be achieved at 1 year. So this was a design based on data at 1 year. We were required to get 280 participants. We, in fact, had to close the gates when we got over 300 because this was a very popular study. We assumed there would be a remission rate of about 5% in the control group because some of them would have heard about the possibility of remission with weight loss and probably would go down the road and buy themselves a formula diet to do it themselves. And of course, with the publicity that Michael Mosley and some of his friends gave us, some of our control participants did actually do that, lost weight, and 1 or 2 of them did get remissions as a consequence. The results are fairly well known now, but staggeringly, we exceeded that target of 22%. We more than double the number of remissions of diabetes. So these are people who at 1 year were no longer diabetic. Hemoglobin A1C was below 48 millimoles per mole, 6.5%, which is the WHO criterion for diagnosis. And they had been off all anti-diabetes medication, including metformin, for 12 months in this particular case. So those data alone set in train all sorts of measures across the country to provide services which would gradually move people towards remission of type 2 diabetes. And part of the reason for this is that this is what patients themselves wanted and began to demand as soon as they heard about these results. At 2 years, that remission rate had fallen to 36%, so still well above the target at 1 year, and a remarkable achievement. And the reason became very clear as to why that figure had fallen. I should mention that at 1 year, the weight losses were approximately 10 kilograms below baseline. Their initial weight loss had been somewhere approaching 15 kilograms at 3 months, 4 months, and that's leveled out at about 10 kilograms at 12 months. So half the patients had lost more than 10 kilograms, and a little fewer than half at 2 years. And that decline in the remission rate was entirely because of 15 participants in the intervention group who regained weight, and their weights became closer to baseline than 10 kilograms. So our data really supported the interpretation of John Dixon in his surgical study, which was that if patients lost greater than 10 kilograms, they were very, very likely to be in remission at 2 years. And virtually all the patients who did lose more than 10 kilograms were in remission at 2 years. So our target of 15 kilograms was there to ensure that a substantial number would get to the 10 kilogram point. It's not necessary for all of them to do so. Those remissions are remarkably well sustained. And here's a figure from a more recent paper, which looks at the remission rate according to the weight loss achieved at 1 year in the pale columns and at 2 years in the darker pink columns. On the right-hand side here are the people who lost greater than 15 kilograms. And you can see that for 1 year, if you lost 15 kilograms, 86% were in remission. Nearly 9 out of 10 were free from diabetes, not requiring medication. At 2 years, 82%. So virtually the same figure, very, very highly sustained remissions if people could actually maintain that weight loss. And you can see that for a 10 to 15 kilogram weight loss, the figures are equally well or even better sustained. And the reason for this is, of course, that the people who slipped out of the 15 kilogram category were very close to 15 kilograms in the 10 to 15. And these are not absolute cutoffs, but they give an indication. Remissions are very, very well sustained, provided the weight loss is sustained. For any given weight loss, remissions rates will be sustained for at least 2 years. I mentioned that we stopped the blood pressure and diuretic medications. A lot of doctors, and Neris mentioned this also, were anxious about this because patients have been on them often for many years, and people assumed that they must be terribly important. The results are shown here. This slide shows just the total diet replacement period, 12 visits up to 20 weeks, and those who got as far as 20 weeks. And the blood pressures are shown here. The white line is people who were never on antihypertensive or diuretic drugs, and their blood pressures fell really very rapidly over the 4 visits. Their blood pressures fell to approximately 10 millimeters of mercury below baseline, and some of them fell extremely rapidly. In the green are the people who had been on one drug for blood pressure, and you can see that their blood pressures also fell to approximately the same level at the end of total diet replacement, 10 millimeters of mercury below baseline. This is an enormous drop, much greater than can be achieved with any drugs for blood pressure. The yellow line is people who had been on 2 or more drugs for their blood pressure, and often these are people who've been on a diuretic plus 1 or 2 other drugs for blood pressure. Their blood pressures, when we stopped them and they went on to total diet replacement, did not change for the first 5 visits, which was up to about 7 or 8 weeks. And thereafter, they fell. And again, that group, their blood pressures were around about 10 millimeters of mercury below baseline. About 30% did require to go back onto medication. That was through monitoring the blood pressure during the trial, and this was done safely. So what we can say is that stopping the medication completely, as people start the total diet replacement, is entirely safe, even for people who were on 2 or more medications for blood pressure, provided the blood pressure is being checked and monitored, and that's often done by the patients themselves and reported back to dietitians or the nurse in the practice, who will then instigate reintroduction of medication if that is necessary. Most of the patients did not require to go back onto medication, and we can say that the effect of total diet replacement for a 12-week period was far greater than any of our medications, drugs that are available to treat blood pressure or diuretics. And I think that's a lesson for all doctors. Neris mentioned serious adverse events. The minor adverse events that we met in the direct trial were very similar to those which had been mentioned earlier, with a bit of constipation, which was usually resolved with the help of a dietary fiber supplement. We didn't have a lot of dizziness, mainly because we stopped the medications that commonly cause that dizziness. We and so the minor events were not actually a problem. We did have some serious adverse events within the 2-year period. And I'm showing here the serious adverse events up to 2 years. Serious adverse events are things which require people to go into hospital, and it would include deaths, although luckily we didn't see too many of them, any of them at this stage. And what we can see is that in the first 12 months, there was no difference between the groups, none at all. However, in the second 12 months, year 2 of the study, there were significantly fewer serious adverse events in the intervention group. That's very unusual for a clinical trial, which are mostly drug trials. We always see more serious adverse events in the intervention group who's given a medication. In this trial, we saw a reduction in serious adverse events, a significant reduction in the second year. It's very early to make any real judgments on this, but it certainly, it is as we would expect from a reduction in blood pressure, reduction in hemoglobin A1C, a reduction in lipids, and also quite a striking improvement in liver function, which we saw in this trial. What were those serious adverse events? Well, in the intervention group, the total diet replacement and maintenance group, we had one patient who had coronary artery disease and a non-fatal myocardial infarction. In the control group, you can see there's a list of complications here, which include deaths, strokes, aneurysms, amputations, and 5 cancers. So these are all conditions which are more common in people with type 2 diabetes and which we would expect to be reduced if there is no diabetes. This is very much in line with our old Aberdeen study, which suggested that people might live same life expectancies if we can get rid of their diabetes. Very early days, but quite exciting data. So in summary, the results from the direct trial, the intervention group had a lower hemoglobin A1C with fewer of the patients on medications. There was a lower blood pressure across the board with fewer requiring medication and less medication when they did need it. The Q risk was halved in this study, enormous reduction in Q risk. And the reason for that was that these patients were half of them were no longer diabetic at 1 year, and about just over a third no longer diabetic at 2 years. And that was a major factor for the risk of a cardiovascular event. Tony, I think Neris also mentioned that we have done very detailed health economic analysis here. There was a reduction in the number of medications used both for their diabetes, for their blood pressure, and other medications which were required less with the intervention. Many other things like painkillers were less often required. Even sleeping tablets were less often required in patients who lost a lot of weight. They had fewer serious adverse events and admissions to hospital, fewer referrals to hospital, or either to see doctors or outpatient clinics or to see dietitians or physiotherapists, fewer consultations for hospital. So much lower costs in the intervention group. And quality of life I've put in sort of yellow here because losing 10 or 15 kilograms in weight really does improve quality of life. Very significant. We had a huge improvement in quality of life. And I think the message here is that whilst losing weight with the dietitian to lose 5 kilograms in weight, which people do, it's hard work. Quality of life, you don't look different, you don't really feel terribly different. 5 kilograms isn't going to do it for you, but lose 10 or 15 kilograms, and that makes a huge difference. I'm not going to try and explain to you the details of this health economics analysis here, but I can just jump to the conclusions of it, and all the data are in the published paper. And that is that we would predict from all the data very similar to those which you heard from Neris, but perhaps more striking because people with type 2 diabetes have got far worse long-term health outlooks than people they were studying in the droplet trial. They would live longer, they would feel better, and they would cost less. So it's a sort of win-win-win situation. And it really begs the question why one would not offer this management program in primary care. The break-even point was at about 5 years. So the upfront costs of setting up the trial or setting up a service and the costs of providing a total diet replacement service, which are similar in this to the ones in droplet, are counterbalanced by savings from all the other things. And that the break-even point is at about just beyond 5 years. What we're doing now, and I was asked to talk a little bit about sort of rollout and where we're going next with all this. Firstly, the program that we used in this particular study was Counterweight Plus, which was a diet program that we developed as a spin-out company from University doctors, and I was advisor to that program. I'm not involved in the company now that it's an independent commercial company. It provided this service that we showed you in direct. During the COVID year, one of the very few things which has come out of it as a benefit is that we were forced, or they were forced, to deliver the entire service remotely. So no face-to-face dietetic consultations or nurse consultations. The total diet replacement is now delivered directly to people in their homes, and the support is given using all the available means of IT with emails and Zooms and WhatsApp. And goodness, we've actually rediscovered the telephone, which I also have to mention was discovered and was invented by a Scotsman many years ago. And these data just show here what is being achieved in, not in the clinical trial, but in the people who are accessing the same program, about half of them with type 2 diabetes across the country. And you can see that after 12 weeks of total diet replacement, their weight loss is 15 kilograms on average, over 100 people in this audit. At 12 months, about half of them have reached the 12-month period. And at 12 months, the average weight loss is 15.8 kilograms. So the weight loss is actually being maintained even better using remote delivery, delivered to people in their own homes, than we were doing with face-to-face delivery in primary care. So this is one of the small benefits which seems to have climbed out of COVID. Now, I mentioned that a subset of our patients were followed up in Newcastle by Roy Taylor. These data have all been published. They're quite exciting. And what they say is, firstly, that people with type 2 diabetes have a very large amount of fat in their liver. They have a large amount of fat within the abdomen. They have big wastes in general. And the liver fat is strikingly increased. And that falls with weight loss in the patients who are in remission. It falls dramatically to normal. That did not happen in the patients, that's in the blue column, that did not happen in the patients in the greenish column who did not get remissions. Their liver fat remained high, and it did not happen in the patient who had relapses at 2 years. And these are the data from 2 years. With the fall in liver fat, there was also a fall in the VLDL, which is the fat being taken out of the liver and transported around the body in the bloodstream. That also fell with remission. And you can see that it actually didn't fall, it actually increased in the people who were who had relapses. So people who went back into diabetes, circulating fat went up. And this effect of circulating blood fats from the liver, the lipids in the blood, was that patients with type 2 diabetes at baseline had fatty tests, and with remission, the fat in the pancreas was removed to become normal. That did not happen when there was no remission, and it didn't happen when there was a relapse. Now, I can show this in even more detail now, a more recent paper which has images of the pancreas. On the right-hand column are data from patients with no diabetes, never had diabetes. And that's an MRI scan of a normal pancreas, and it shows the volume, its shape, and its insulin production. So a patient with type 2 diabetes at baseline on the left has a very ragged, sick-looking pancreas. It has low volume, it has a very ragged surface, and the insulin secretion, this pancreas is not able to make a normal amount of insulin, less than half the normal amount of insulin. And you can see that as these patients went into remission, very gradually, over 2 years, there was a steady increase in the capacity of the pancreas to make insulin, and it became normal. 2 years, the pancreas was making a normal amount of insulin under maximum stimulation. And the shape of the pancreas at 2 years was really indistinguishable from a normal pancreas. There'd been a full recovery of the morphology of the pancreas. So, DIRECT trial is telling us something, or confirming something very fundamental about what happens when people put on weight. And I think what we've got here is a situation where about, in Western populations, or North American population, European, about 60% of people, and you may be lucky yourself, or you may not be, but if you're in that 60%, you can gain weight, and you may get complications like arthritis or indigestion or other things, but you will probably not get a lot of them if you're in that 60%. You'll get some increase in heart disease, but not a lot. However, about 40% of all people listening to this talk, all people across our population, have the predisposition, genetic, epigenetic, for metabolic syndrome. And we know some of the genes, we don't know them all yet. But if those people, about 40% of all people gain weight, at some stage, they will start putting fat, ectopic fat, into the liver, into the pancreas, into the heart, and they will get horrible complications, which are irreversible. So once you've had a heart attack, or you've got a microvascular disease and you're blind, or you've lost your kidneys, that's a bit too late. However, what we've done in DIRECT is show something very simple, is that at least at an early stage, we can reverse that. We can lose weight and we can get rid of that ectopic fat. And if we extrapolate on to our old Aberdeen study, it looks possible that we can then avoid the long-term complications. You can't get complications of a disease if you haven't got the disease. So these people no longer have diabetes. To finish up with, I'll just show you very, very quickly a new systematic review that we've done of all the clinical trials and studies, not just clinical trials, which have looked at remission of type 2 diabetes. It's a new sort of buzzword. It's a very new word, and it wasn't understood by doctors until about 3 years ago. Now, I think pretty much every doctor in this country is talking about remission of type 2 diabetes as an important target. So I've told you about DIRECT. A very similar study called DIADEM-1 was conducted in Qatar, and a slightly smaller study with essentially the same protocol, very good weight loss, 12% at 1 year. These are 1 year data. And using an intention to treat analysis, they got a 61% remission rate, tremendous remission rate, even better than in DIRECT, but a remission rate of 12% in the control group. And the reason for that was that with usual care in the control group, these are slightly younger people with more recent onset diabetes, only up to 2 years from diagnosis. And also, of course, they had the confidence of knowing the results of DIRECT, that this was highly likely to be successful, but very strong confirmatory data. Several other studies, and they're shown here, have looked at low-carb diets. And there's sort of a bandwagon effect here that many groups have said, oh, well, we'll look at our data retrospectively and see what we got in terms of remissions. There was a study conducted by the Virta Health Group, in a big commercial company in the United States, which promotes low-carb diets, ketogenic diets. They have very good weight loss, 13.8 kilograms, but a very poor remission rate. So the low-carb diet is not providing the solutions that patients need here. This figure, I'll qualify it, then there may have been slightly more remissions than they were able to demonstrate because they didn't stop the medications to be completely sure whether they'd got remissions in all the other participants. This was not a randomized controlled trial, so it only took the sort of best people who were willing to continue with the trial. David Unwin, as a GP in England, he did a remarkable study in his practice. He asked every patient with diabetes, 473 of them, to go onto a ketogenic diet. Across the board, he got a remission rate of 12.5%, which is really excellent at 2 years. Of course, a lot of the patients, most of them were not happy to do that. But those who stuck on that diet, over 100, they got a 46% remission rate of diabetes. Very remarkable. Other studies have had much less successful results. And I just mentioned at the bottom here, the look-ahead trial, biggest ever trial conducted in type 2 diabetes, was not designed to get remissions, but it did have an 8.6% weight loss in a group of patients who had much longer duration disease, and they had remissions of 11%. So the pattern here is very consistent. The more weight loss you can get up to and above 10 and even 15% will give remissions very reliably, but you need to start as early as possible. If you leave this until diabetes has been there for several years, you're going to miss the boat. Rolling out this program, very quickly, Diabetes UK put together a paper called the DIRECT Principles paper, which sets out the principles within the intervention program that ought to be able to produce remissions when delivered in other settings. So there's nothing magical about the program that we used. The formula diet was certainly not magical. The program, the educational program, Counterweight Plus, we had spent the best part of 10 years developing and evaluating. Other people will do something similar, and we hope that they will be successful. What is happening now in the UK is there's this very rapid understanding that remission of diabetes is possible, and the patients are jumping up to their doctors and saying, come on, we want this. In Scotland, every health board is now able to deliver and has trained staff to deliver the Counterweight Plus program. So the decision in Scotland was to go with the evidence-based program, the one that works and has been shown to work, with the support program that has gone into it. And the training is not onerous. As I say, it's now available in every single health board across the country. In England, a pilot study has been set up of 5,000 people, but using other diets, a variety of diets, which are sort of lookalike diets of one kind or another. And we have yet to see how successful they will be. And I've listed here a number of other programs across the world, which I'm involved with. So there's a study in Europe, which is doing a direct comparison between a total diet replacement and low carb diet program. Very difficult to do, but we've got one planned up and just needing funding to do it now. And it's already funded in some countries, but not yet in the UK. I'm involved in 3 evaluated programs using total diet replacement in Australia. One of them is using Counterweight Plus, another using, I think it's a Nestle product, but there's no magic in that. In New Zealand, Pricewaterhouse has done a huge evaluation of diabetes as it affects the economy and health services. And not surprising, they have now recommended the use of total diet replacement as routine treatment. That has gone to government and decisions will hopefully come down. They make good decisions in New Zealand, by and large. I'm involved in a program in Nepal, where formula diets are simply not an option because ordinary people do not have sufficient money to pay for this sort of thing. So we've had to develop food-based approaches. And similarly in India, where diabetes is so common in poorer communities, and we're trying to put these 2 programs together. And then there's programs in the United States, and there are many of them. I'm just involved in one. So there's a lot going on. This slide shows Scottish food-based approach, which is called the No Doubts diet. It's a bit of fun, but it actually works. And that is to have a bowl of porridge in the morning, a bowl of lentil soup at lunchtime, and then another bowl of soup at dinner time, but different lentil soup and a piece of fruit with each one. 830 calories a day, 850. And in Nepal, again, traditional diets. So the message here is that if we can adapt traditional diets, we can approach the same sort of 830, 850 calories a day for weight loss induction, and then move gently on to maintenance using traditional food stuff. So here are the summaries. We must treat type 2 diabetes and obesity, the disease process, much more seriously than we have in the past. Type 2 diabetes is at least as serious as some major cancers, and we need to treat the treatment as seriously as we would chemotherapy. We have an optimal diet program in terms of Counterweight Plus, which is well evaluated. We have the principles which can be applied elsewhere and evaluated. And we should, I think, be targeting 15 kilograms weight loss in Europeans, certainly, with the aim of getting the maximum number past the 10 kilogram cutoff. In Asians, it's possible because they start at a lower weight and have a different body build, that we may be able to get by with a 10 kilogram weight loss. And we have a pilot study looking at that at the moment. But the big issue is long-term weight loss maintenance. I'm sure that's where our discussions will take us. So a huge thank you to everybody involved in the direct trial, particularly to the foresight of Diabetes UK charity on behalf of people with diabetes.